Alrighty, so today's lecture is going to be a quick one. I'm just going to talk about vulvar pathology in the Oxy and hemoglobin dissociation curves, and then a few questions involving that. So, the vulvar pathology, again, the vulva involves the external introitus to the vagina. So this is superficial pathology. So vulvar pathology can be divided into non-neoplastic and neoplastic. So the non-neoplastics, we start with the Bartholin cyst and abscess. So this is essentially a fluid accumulation within the glands. And I know we've talked about this before, but it's normally an abscess that forms secondary to an obstruction and inflammation. And it is associated with Neisseria gonorrhea infections. And if it is asymptomatic, you normally leave it alone because it will regress. But if it does get painful or swollen, and because it is associated with Neisseria, if the patient complains of fever and it starts to get bigger, then you will have to do an incision and drainage as well as antibiotics. So, but I just finished all of the OBGYN questions in UWorld, and that each one that involved a cyst was all just observe and send home. So, yes. So next we got lichen sclerosis. So this is the thinning of the epidermis and fibrosis of the dermis. And it is always described as white plaques, like you can see here, here, around red-violet borders, like we see around here. So that's a pathognomonic presentation there. And it normally occurs in postmenopausal women. Why might we be seeing it in postmenopausal women? Why in this population? A lady that's 62 will come into your office. She'll be complaining of itching, burning on urination, dyspareunia.
Is it something to do with like the normal flora not as, I don't know,
close?
not
Something
doing
is
his
abnormal.
job as
What
usual.
hormonal
Lack of
what
estrogen?
hormonal changes?
Estrogen.
There we go. Low E. Because estrogen is going to add pliability to the epidermis. So when we have low estrogen, women are going to present with more frequency, urgency, UTIs, because there's less elasticity to the epidermis. So if there is any kind of quote-unquote trauma, which could be either intercourse or it could just be wearing underwear that is constantly pressing up against and rubbing as they walk, could cause this kind of presentation. So it's normally going to be older patient. And the treatment for this is topical steroids, clobetasol. Okay, so this is a totally random side question that I just thought of. In what scenario might we see a younger patient with lichen sclerosis?
They're on OCPs or
think something more dramatic than that, because normally OCPs it's cyclic, so they're still going to get estrogen.
if they are on what is
Not
it?
drugs. So where do we get our where do ladies get their estrogen from?
Like growth hormone, or are you talking about
Ovaries?
Yes, the ovaries. So if you have a patient that had a bilateral oophorectomy, let's say, because maybe she had a cancer, so if you have no ovaries, then you're not going to have as great of an estrogen supply. So this could be a scenario where you might see a woman in her mid to late 30s that's presenting with menopausal symptoms, which could end up being lichen sclerosus. Just a random question I thought of. Okay. Oh, and yeah, okay. Now I forgot. See, I didn't even check to see if there are animations. So, there is an increased risk of squamous cell carcinoma, and that's why whenever you see this presentation, you want to biopsy it. So you can do a punch biopsy on any patient that does present with this. And again, white and velvet, or white plaque with velvety red borders. And then we've got lichen simplex chronicus. So this is hyperplasia of the vulvar squamous epithelium. And this has more of a leathery thickening of the skin due to rubbing, and there isn't an increase in the squamous cell carcinoma. So we have lichen sclerosus, which is a thinning, and then this simplex chronicus is a thickening. And actually, I don't have it here, but now that I've seen it in other texts, lichen sclerosus is described as cigarette paper in appearance. So, again, just very thin versus a thick, leathery skin of lichen simplex chronicus. So, those were the non-neoplastics, and now we're going to the neoplastic vulvar pathology. So, we've got vulvar carcinoma. It is rare, but it is squamous skin, or carcinoma of the squamous skin. So, squamous cell carcinoma. It can present with leukoplakia, like we can see here, this thin white border. And it is related to HPV 16 and 18, and non-HPV related is from long-standing lichen sclerosus. So like we just saw here, in lichen sclerosus, there is an increase of squamous cell carcinoma. So that would be where this comes into play. This is why when we see lichen sclerosus, we want to biopsy it to rule this out. And you can get tricked because it'll say, oh, there's a white lining here. But the difference here is the leukoplakia is typically going to be the border of the cancer, whereas in lichen sclerosus, it was white plaques with a velvet border. So that's the difference. If they don't say anything red, velvety, then it's not lichen sclerosus. But if they say, this is clearly indurated, this big lesion with some white borders, then this is going to be the cancerous lesion. But either way, you're going to biopsy this, whether you see it or not, just to rule out carcinoma. And we've got extramammary Paget's disease, or Paget's disease of the vulva. This is, Jesus, sorry, my phone's going on. This is intraepithelial adenocarcinoma, carcinoma in situ, which means we know that it has gotten through all the layers of the epithelium, but is not busted through the basement membrane. So patients are present with pruritus, erythema, and crusting of their ulcers, and there is a low risk of underlying carcinoma. Excuse me. So, as you can see, we've got this big old lesion here that's got kind of a red erythematous border around it. But this is going to be a pretty obvious kind of presentation because, again, it's crusty. That's going to be the main thing here. So the way to differentiate it is this one's going to be a crusting lesion. This guy's going to be indurated, like this lichen sclerosus is going to be red and velvety. Red and velvet. This one, which they don't have a photo in first aid, this one's going to be leathery, thick skin. So, and then the Bartholin's gland is going to be kind of obvious, just because it's going to have this big old mass. It's going to look like a fluid-filled abscess. So all of these have a very distinct presentation where you would be able to distinguish them either from an image that they provide or from the vignette presentation. So, anybody have any questions on either of these first two slides? No? All right. We're going to move on to the oxygen hemoglobin dissociation curve. So, we've got this curve that everybody knows about. It's basically showing how oxygen binds to hemoglobin. So we are going to talk about this hemoglobin curve first, and it is described as a sigmoidal shape. Now, why is this curve sigmoidal?
Because of the changes in affinity for oxygen, depending on how, like, whether one molecule is bound to it and then the other ones can bind more easily and then unloading to tissues.
Right. So it's called positive cooperativity. Tetrameric hemoglobin molecule can bind 4 O2 molecules, and the affinity for it increases with the addition of every O2 molecule. So right. So there's a lower affinity for it here. So it's further to the left, and then as oxygen molecules are binding to it, there's an even greater affinity until it plateaus. Right. So I mean, this never really shows it very well, but if you want to think of it more like this, where you actually see a sigmoid to the curve, just a little more discrete there. Okay, so why does myoglobin have this exponential? But
Because of its shape.
What about its shape?
It's not tetrameric, it's, I think, monomeric.
And it wants to
There you
unload.
go. Well, yeah, no, he said nailed on the head. It's monomeric, so that means as soon as there's either no oxygen on it or it's completely filled. So there's no room for there to be positive cooperativity. So that's correct. Okay, so you might see a question about the shape, and that's as much as they can ask you. But the real meat and potatoes of this topic is the shifting of the curve. And so when the curve shifts to the right, what happens?
There is decreased affinity for oxygen, so the tissues want the oxygen more than the hemoglobin molecule. So it goes that way.
Yeah. Because aren't you shifting more P50? Isn't the P50 increasing?
The P50
Yes, it would be. The P50 would be increasing.
Right.
Because you need a higher oxygen amount to maintain that saturation point.
Yeah. Okay, so it decreases the affinity for hemoglobin because we want to unload the oxygen once we get enough. Okay, that makes sense. So when we're moving this way, we have an increased affinity because we don't have as many spots filled up. Does that sound right?
Yeah, it's, that shift would be like the hemoglobin F scenario where the oxygen is held on more tightly, like you said, increased affinity.
Okay. So as we have an increase in all of these factors, which is ACE bad, that's right, acid, or meaning basically H molecules, carbon dioxide, exercise, 2,3 ppg, altitude, and temperature, we're going to see things shifting to the right. So as the increase, we shift to the right. And then opposite, as these things lower, it's going to go to the left. So we'll talk about fetal hemoglobin. What is special about fetal hemoglobin as far as affinity goes?
It has a higher affinity for oxygen.
Right, higher affinity to the adult hemoglobin due to low affinity for 2,3-BPG. The dissociation curve is shifted to the left, so it looks like this. Still has the signal shift, but it's swapped over a bit. So what is 2,3-BPG?
Byproduct of glycolysis.
Good. Yeah, that's right. So what does it do to hemoglobin? Why do we talk about it?
It binds to deoxygenated hemoglobin.
Right. It's the guy that wants to facilitate the unloading. Correct. So I'm gonna bring this up for another question. But so like we were just saying, when things increase, like increase 2,3-BPG, then we're going to be moving things to the right, and like you guys said, that's going to be decreasing the affinity, meaning we want to unload the oxygen. Makes sense? How about carbon monoxide?
Take the place of oxygen?
We're going to increase or decrease the affinity?
Will it increase the affinity? Because doesn't it bind more quickly than oxygen to hemoglobin?
Right, so it has a greater affinity to the binding sites, but what does it do to oxygen's hemoglobin?
Decreases its affinity?
To be honest, I think I worded that question wrong. But, okay, so it's not going to change the affinity. It's going to decrease the potential for saturation. This would be carbon monoxide. The reason is because if you got hemoglobin, 4 oxygen binding sites, 4 possible oxygen binding sites, and then you got carbon monoxide binding to a couple of them, the affinity for oxygen hasn't changed in the remaining sites. It's just these 2 spots aren't available anymore. Affinity for hemoglobin for carbon monoxide is 200 times greater than that. When carbon monoxide binds to one or more of the 4 heme sites, hemoglobin shifts to the relaxed configuration, causing the remaining heme sites to bind oxygen with higher affinity. Okay, so never mind. So it'll increase the affinity. If we're increasing something, and we'll move it to the right, guess we put dioxide and monoxide in it. I guess we can think of it that positive cooperativity occurs as long as something is sitting in the chair. You know what I mean?
Mm-hmm.
There'll be a higher affinity because, you know, it's like, what's that game called? Musical chairs. The oxygen wants to sit down in a chair, and there's only 2 chairs left, so they'll try and rush to the spot faster. As a result, the affected hemoglobin is unable to release oxygen to the tissues, leading to tissue hypoxia. Alright, well, sorry about that, guys. I didn't fully clear that one. Right now.
So if I read that correctly, that would cause the increase in the affinity would cause shifting of the curve to the left.
Yeah. It should shift it to the left because you're going to decrease unloading. So would it be more like this? Because this is saturation, so the oxygen saturation is going to be decreased. just because there's only 2 spots. Let's just say it's half and half. There's only 2 spots that have been taken up, but the P50 is still decreased.
That makes sense.
And with oh, wait, yeah, I just found something. Decreases oxygen carrying capacity, shifts oxygen hemoglobin dissociation curve to the left, binds to myoglobin and mitochondrial cytochrome oxygen. Okay, well, that's different. Okay. Sorry for the confusion, guys. Sorry.
Okay.
Everybody okay on this? Is everybody okay on this curve now?
Yeah, makes sense.
Okay, well, let's test our confusion on some questions. So we got a 67-year-old man is brought to the is brought by EMS after being found unconscious and on the floor of a burning building. On exam, his respiratory rate is 14 breaths a minute with scattered wheezes. There's no evidence of any burns, but there's dark soot caked around much of his face. Suspecting inhalation injury, you expect this man's oxygen hemoglobin curve to be A, unchanged due to the fact that carbon monoxide is largely unbound and dissolved in plasma. 2, shifted to the right. B, shifted to the right due to strong competition between carbon monoxide and O2 for binding. C, shifted to the left due to tighter heme O2 binding. D, shifted left due to metabolic acidosis in tissues. E, shifted to the right due to decreased affinity for oxygen.
C.
Yeah, second that.
Yep.
Right. I didn't do stuff, but yes. So we just talked about shifting over to the left because we're decreasing the unloading of oxygen because of the positive cooperativity. Okay. 45-year-old man was brought to the ER after he was found nearly unconscious in his garage with his automobile running. Which of the following is most likely to be decreased in this patient? So arterial oxygen tension, blood hemoglobin levels, heart rate, P50 of hemoglobin dissociation curve, or respiratory rate.
D.
Right. Because again, if we're shifting the curve to the left, then our P50 is going to decrease. Everybody get that one? Is it cool?
Yep.
What happens at high elevations? I'm not going to read that. I'll let you guys figure out. So we're talking about 2,3 BPG and affinity for oxygen. So which goes up, which goes down?
2 to 3 BPG would increase.
It's a right shift, so affinity for oxygen decreases. So, A.
Right.
Correct.
Got increase BPG. So that is going to, so that shifts the curve to the right, right? Yeah. So that means we're going to have decreased affinity. Okay.
Or O2 unloaded.
Right. And that's my spiel.